Sanjeev and I will run the webinar today. We like to keep our webinars, for those of you that have attended before, very interactive. So we will pause for questions. Can I ask that if you have any questions, please pop them in the chat, and then we will take pauses and go through the questions and then circle back to the presentation. The reason we do that is because what we've seen, and from experience, obviously, that especially in primary care, you need to understand how this will work at your practice. All of you work in a fairly unique way. So we have no issues with questions. Please pop them in the chat. We'll do the presentations in stages, stop for questions and circle back. So for those of you who've just joined, we are recording this webinar, and then what we will do is share the recording afterwards and post it on our YouTube channel. We're going to run through our pathology management platform first, which works with both EMIS and System 1. And then after that, in about 25 minutes or so, we will run through our document automation tool. Okay, so thank you for joining us today. As I mentioned before, Sanj and I will run the presentation today. The first tool is our intelligent platform, our intelligent pathology management platform. The principle behind this tooling is to free clinical capacity by using automation, in addition to error mitigation, reductions in errors, and faster processing. So we are an NHS ICT partner, which we will come back to a bit further on in the presentation. We are a private UK business. We are not an NHS, obviously. We're a private UK business, but unusually we're an NHS ICT partner, which means we have access to NHS Cloud, which means for those of you that acquire the toolings, things like DTACs, DPIAs, data sharing agreements are really straightforward. Nothing leaves the NHS, and I'll come back to what that means in a moment, as that's applicable for both products. So our path management platform is to free clinical capacity. This platform is super popular. I believe we're touching somewhere in the region of 3.5 million patients now, and processing thousands and thousands of pathology tests every single day across the country. The principle is to give back clinical time. Current estimates are we can give back each clinician approximately 30 minutes a day. So if you have 5 clinicians, it's 5 times 30, 3 it's 3 times 30, 10 it's 10 times 30. And that enables them to focus on care, free time, and maybe not sit there in the evenings doing path report checks. Perhaps they can get some time off and watch TV. So here's the challenge. The business case for this challenge is a practice with 8,500 patients. And we just do that because you have to have some kind of business case in order to quantify the figures. So this 8,500 list in the UK will receive approximately 62,400 pathology tests a year. That figure is quite accurate. So what we mean by that is a practice with double the patients will receive, give or take, double, and a practice with 50% will receive approximately 50%. In addition to that, the 5 partners would double or reduce by 50%. So the physical workload that the partners are forced to do remains the same. So with path tests, obviously there's quite a significant safety risk. Our tool focuses on the normals and running patient contextual checks on the normals, and it mitigates that the safety checks, and we can show you what that means in a moment. So this is the scenario. This 8,500 list, which generates approximately 62,400 pathology tests every single year, all of the clinical interpretation is done by clinicians. So that means that every single path test is opened and interpreted by a clinician. Notwithstanding that, approximately 80% of those tests, which equates to just under 50,000 tests a year, come through as normal. Now, in addition to that, 20% of those 80 checks, so those 20% of those 80 checks come through as normal, but there might be something in the patient record that means that the clinician would not want to miss that test. They want to continue their exploratory work on the patient. So what do we mean by that? Some path tests come through as normal. They can be filed, don't need to be looked at. It's a complete waste of clinical time opening a path test that is normal, and they know it's normal, just to file it. Well, we can do that doesn't have to happen anymore. In addition to that, they receive thousands and thousands, approximately 20% of the 80%, which in this scenario is nearly 10,000 tests a year, come through as normal, but there might be something in the patient history that means that the partner, the clinician, the GP would want to do further exploratory work on that patient, and they don't want to miss that. In addition, when you think about it, why would you have your highly skilled resource that's already overworked opening path tests just to double check something and file it? And then why would you have them opening something, reading it, and then going into the patient record to look for a health condition or a percentage increase or decrease or supersede in terms of age or gender, to then either file it because they didn't find it or flag it and continue their exploratory work because they did find it. Our tool does all of that in the background. So what it ensures is that when they open their inboxes, or when you open your inbox, you are only looking at pathology tests that you want to. So they are either abnormals or they are normals that have failed a patient contextual check because the groundwork has been done for you. It also improves safety, as we touched on before, because you're enforcing those rules now at practice level. Or MyBotGP is a big filter at the front of the practice. All of the pathology tests will pass through it. It will do the initial vet, screen, and sweep, and leave you with the ones that you want to look at. We can read path reports. Our tooling is looking after 200 different pathology tests now, which equates to around 95% of all your path tests. So if you bring it back to this first page, this 8,500 list, half an hour a day per partner, which includes going back to double check errors and stuff, not just what they do on a daily basis, works out £50,000 a year of practice annual clinical capacity cost allocation is spent on this task. About 16 weeks of time. And that's essentially what MyBotGP will remove for you. So 1.5 days per week for this 8,500 list, which is 95 days a year of capacity released and cost reduction. So think of it this way. Path tests arrive and they sit in 3 buckets. All path normal, don't need to do anything with it at all. Don't even need to see it. Can just be filed. Normal, but requires a patient contextual check to determine whether you do want to continue your exploratory work on that patient, for example, having a health condition or percentage increase or decrease, or abnormal. So MyBotGP, because it can cope with 200 different pathology tests, and we do have some clients that actually have 2 labs, so that's 400 different pathology test types, will run the initial sweep on all of your path tests. Excuse me, it can be bespoke at practice level. And we'll cover off what that means in a minute, because different practices have their own protocols that they like to run. They can be replicated as well. We're not here to tell you what to do. You can bespoke the tool to replicate your protocols. So initial safeguarding is done, and it will decide whether you need to see that path test or you don't. And there's a massive time saving. And obviously, if you would like to send text messages, the kit is capable of sending text messages as well. So our tooling is a medical device. We have a DCB 129 certification, and we'll cover off that stuff in a moment. So I'm going to run through the rules now, then I'm going to share a spreadsheet very quickly just to give some examples, and then we'll pause for questions, and then we'll circle back again. So if you, again, as I said at the beginning, if you have questions, please pop them in the chat. We'll wait, and then we'll go through them all one by one, and we'll answer them all with everyone together. So first bucket, which is over here. 200 different pathology test types can be run through MyBotGP. If there are more path tests, we would be able to process more, which equates to around 95% of all of your tests. So we're not saying we can only run flows for a few. Okay, first rule, range control. Do you agree with the lab? What do we mean by that? Well, our clients, there are some path tests where they are happy to file as normal based on a lab range, or happy to file as normal based on a lab range after a patient contextual check. And there are some path tests where they don't agree with the lab and they would like to supersede the lab. So our kit will allow you to do that. So you can agree with the lab, or you can set your own ranges. Examples of that are things like some of the cholesterol tests, some of the subtests in full blood count, prostate. Most of our clients supersede labs ranges for 5 age ranges and 5 PSA ranges, EGFR, and again we'll show you some examples of what other people do. It's completely up to you. Do you want MyBotGP to check for a health condition? So it can go into the patient record and check for a health condition. So you can say, I'm happy with this lab range as long as you don't find this health condition, or I don't agree with this lab range, I want to supersede it as long as you don't find this health condition. So these aren't individual rules, you can combine them. You can compare tests against previous test results, which is the bucket over here. So you can say, I'm happy to file this as long as it hasn't moved up or down by a certain percentage. We see that a lot for some of the EGFR tests. Or you can supersede the lab and check for a condition and do a comparison for percentage increase or decrease. You can supersede in terms of age and gender. In addition to that, what's massively important is our kit is the only kit that can actually read pathology test reports as well. So that's important because you will get thousands of pathology tests a year that do not have ranges. So that's another whole tranche that we can help clean for you and make sure that you're seeing the ones you want to. So they might have keywords on there like positive or detected or so on and so forth. Other path tests have warnings on there. So pre-diabetes, for example. So some of our clients say, happy to agree with the lab, 20 to 41. As long as it doesn't say pre-diabetes, then I want it flagged, or diabetes in the patient record. Obviously, you can exclude some patients if you want. And if you would like to send text messages, you are able to. And that will link up to Accurix or whatever platform you're using at that time. And it will use all of the functionality there, and you only send text if you want to. You'll just say per path test type. So a couple of examples before we open up the spreadsheet. Most of our clients supersede prostate. They put 5 age ranges, 5 PSA ranges, and a patient contextual check to see whether the patient's had cancer or prostate cancer or metastatic cancer. If it spots any of those conditions, it will be flagged. If it doesn't, then it will supersede the lab. 2-3 years ago, clients for prostate used to say, happy with the lab range, a fail is a fail. If it's a pass, I still want you to go back in the patient record. If they've had a previous test, use the comparison functionality and see if it's gone up by 5 or 5%. If it has, flag it because that's too quick. HbA1c, EGFR, and some of the examples I gave before. So this is your tool. It's your MyBotGP. We will configure it for you. It's quite quick to configure. It's an hour and a half to configure. You can log in and out of it whenever you like. Again, why is that important? It's important because you will change your mind. We've seen that across our client base. Periodically, you'll want to go in and adjust some of the path tests yourself. Also, your lab might change a range. So you need to be able to adapt the tool. It's super easy to configure. Again, this slide is small. Small intentionally because we could spend an hour just on the front page and we want to get through the functionality. But what you're looking at here is the interface, and it essentially says these are the ranges that the lab gives for a liver function test. So you look at that test and say, do I agree with the lab? If you agreed with the lab and you were happy to file that test and you didn't need to run any patient contextual checks, you didn't want to supersede any of the ranges or anything like that, you would click File for Normal Report, which is here. It would flash up a warning and say, are you sure? If you then validate that and say yes, then from that point onwards, every time you receive a path test within these ranges, nothing fails, it would be filed and you wouldn't need to see it. Now, if you don't agree with the lab, or you do agree with the lab, some of it, but you want to supersede some of the checks, then you don't click that report. And here you can see you can quite easily just click this button here and change a range, or you can say previous test result check. You just click whichever one you want for the percentage increase or decrease. And here is our keywords. Super powerful in terms of adding the additional checks. So keywords is loosely what we refer to as any word you want to write in there that's the you want MyBotGP to look out for to be present or absent. So that health condition, warnings on the pathology test report, path test reports that don't have ranges, and so on and so forth, and you would write them in here. Now, because MyBotGP uses EMIS and System 1 in exactly the same way as a user, which is really important, when you file and your comments and filing strings, they will still be updated in exactly the same way. So what that means is when your patients log into their app, nothing will have changed. They'll still see the path test in the app. We're not taking anything out of the system, and it's not leaving anywhere. It's simply being done for you, like a remote worker sitting at home. So here's a couple of examples that we have here, but actually I prefer just to share this very quickly. Just open up this spreadsheet. Sanj, is this spreadsheet showing? Yeah, okay. So what we're looking at here is an indicative snapshot of 181 different path tests. So this particular client that we have has 181 different path tests. Some have got more, and again, it's not an issue how many. The tooling can cope with as many as you have. And you can see here enabled. And what these are these are the path tests that they've given MyBotGP responsibility to look after for them. And across here, you can see the rules. Combination of the rules that they've given. Now you might have a difference of opinion, and obviously that's completely fine. This is just indicative. You can bespoke as you want. So I'll just give a couple of examples here, and then we can stop for questions, and then we'll circle back. So enabled means they've given it permission, and we've essentially they've let us download this list to use for demo purposes. So what you're looking at here are the rules essentially. So that's the path test name, subtest name, gender, age. Check for normals, ranges, check against the previous test result, keyword check, comments and filing strings. Okay, as you can see across here. So essentially that is, as we were just saying, if I open up the right one here, that is the rules. Range control, supersede the lab, agree with the lab, check for health conditions, compare against previous test results, read the path report, age and gender. Oh, Sanji, I think someone's up. I can hear myself echoing. Ah, okay, it's better. Okay, so open up this here. So if we look at the first one, again, this path test is not one that you'll be requesting for thousands and thousands of a year, but it's a good example. It's top of the list. This is 24-hour sodium, 24-hour urine sodium. This particular client receives it like this, 27 to 287. I don't believe they've superseded the lab. They don't believe that they need to add any additional patient contextual checks in terms of age or gender. They don't want to supersede it. They're happy to file. However, what they have added is they've asked MyBotGP to look in the patient record and see, if you look in the top left-hand corner, if the patient has diabetes or chronic kidney disease. So for them, they've said happy to file it as long as it's within range, unless you see that. So in this scenario, MyBotGP will pick that test up. If it doesn't see that, it will file it. If it does see that, it will flag it and leave it for the clinical attention. The next one here, this is an example of the prostate example that I gave before. Lots of our clients are doing this now. Not everyone, but lots are. This particular client has superseded their lab. So what you can see here are the age ranges. They have 18 to 39, 40 to 49, 50 to 59, 60 to 69, and 70 to 150. And they've superseded the PSA ranges from 2.5, 2.5, 3.5, 4.5, and 6.5. So they're essentially saying, I'm setting new ranges. These are the age ranges, and these are the PSA ranges. However, it goes without saying, in addition to that, they've asked MyBotGP to look in the patient record to ensure the patient hasn't had prostate cancer or metastatic prostate cancer. As if they have, that test needs to be flagged, despite obviously the ranges being superseded and so on. There's another example for lipids, and again, we could spend ages going through all of these. We're happy to share these afterwards unless you've had them already. Most clients supersede HDL to 5, and then again, you can see here the keyword checks in the background to make sure that nothing slips through the net. So if we circle back to the principle behind this tool, it is there to free clinical time, stop clinicians from having to sit there opening normals and just file them for no reason, or open other normals and then have to physically check in the patient record for any number of different things, and then file or flag. It does everything for them, and you know, once you buy it, you're not going to turn it off and start doing it manually again a couple of years later. And there's obviously the time saving, and in addition to that, there's the additional safety, because nothing will slip through the net. If you want to set multiple patient contextual checks on multiple pathology tests to ensure that nothing slips through the net, MyBotGP will do it for you in the background. Runs 7 days a week, and obviously you get full audit logs. So HbA1c example here, 20 to 41. This particular client's lab sends a warning pre-diabetes, so they've said have a look for the warning. In addition, also checking the patient record for diabetes. So if I close this down now and bring it back to this, yeah, I mean, by the numbers, this is just more around the business case, sort of the financial business case, notwithstanding the reduced stuff slipping through the net. This is based on an 8,500 list. And there's a bit more about our certification. So class as a medical device, we have DCB 0129 certification. Our clinical safety officer is a UK practicing clinician, which we thought was very important. We also have built a DCB, or rather our safety officer has built a templated DCB 160, which we share with clients if you would like it. Everything resides in NHS Cloud through our partnership, which means that we can literally just plug you in. DTAC, DPIAs, data sharing agreements, no complicated installs. And we were Health Innovation Launchpad graduate several years ago. Costing is quite straightforward. Unlimited pathology test types and unlimited volumes. So we don't charge more for more tests being processed. And that's 200 path tests, thousands and thousands a year. This 8,500 list comes in at about 3,887 plus VAT, which works out, give or take, £75 a week. And in principle, you're getting 1.5 days of clinical time back for £75 a week. Even if that was 1 day a week, it would still be £75 a week. The pricing mechanism is list times 30 pence. And then depending how many patients you've got, it's a combination of 5, 6 or 7 pence. But if you take that as a ballpark, and it's not double if you have a double list, because that's a fixed cost. So it will go up or down by sort of 30 or 40%. Okay, it feels like a good place to pause for a moment. Sanj, has there been any questions? So I'm going to pause for a second now. Good stuff. Right, if you can pop questions into the chat, I'll stop sharing my screen here, and then we can share the chat. Okay, so we'll rush through these. And then we will move over to our Docman automation. So Sanj and I will cover both of these. So if I read them out. So first question from Rachel: when it searches for medical conditions, is it looking for? Oh, hang on a sec. Got pushed down to this. Is it looking for read codes or free text too? I can answer that one unless you want to, Sanj. Or yeah, okay. Free text as well. So our safety officer recommended that we have it look for free text because invariably some stuff isn't coded in or it's not coded in correctly. So we were advised it's safer to actually look for free text. Then you can write the word in and it will search the entirety for the word. Second question. Great initiative, thank you. Is it related to Plantit AI at all? No. No, we've avoided AI. The way to think about this tool, Mohammed, thank you, is this is a replication tool. It's an automated replicated decision tree which keeps it safe. So essentially what it's doing is it's mirroring what you would do manually. So manually, I'm going to look at this, and every time I see this, if I like to do that, it's going to do that. It's not going to go off on its own and start thinking of different ways to do things and other ways to accept it. So we've kept it nice and safe within the guardrails. It's a clinical replication. It's a super complicated one, but it's essentially a decision tree replication protocol. We've just done the CSO. It's not AI. Yeah, CSO practices are supposed to have a CSO. Yeah, and we will share the DCB 160. What typically holds practices back for adopting MyBotGP even when there's a clear potential benefit? It's a good question. That's a really good question. We not as much. So what we've seen in the last, I'd say, year or so, that's not as much of as an issue as it was probably a year to 18 months before that. Most practices are quite keen to proceed because it's not a brand new concept in terms of automation. So I think it comes down to money, potentially. If they're happy to invest the money now to get the benefit, they will buy it. SNOMED codes no longer use read codes. Thank you. Great, thank you. Okay, so I'll hold. Sorry, Sandra, I took all the questions. I'll leave you to the Docman ones. Please, if you've got any more questions, please pop them in the chat. And then if not, we'll move on to the Docman automation. And then what we'll do at the end, very happy to open up the floor again and then go back and forth with questions if you've got any on either product. So if you have anything else you'd like to ask, please ask now. If not, we'll move to the Docman automation. can you share any examples of problems that practices have had adopting MyBotGP? Interesting. It's not problem, time allocation. So essentially, when we first launched this product, clients were doing the configuration themselves. What we saw is that we can significantly reduce the time that they allocate to this if we do it for them and with them. So I'd say in the last 6 to 8 months, all of our clients, we do the onboarding for them, 2 45-minute calls. And they're fully up to speed, and then that's dealt with the issue around getting it up and running as quickly as possible. Okay. Does it work on ongoing paths? It works. It logs in and out throughout the day, so it will continually empty the inbox. So it doesn't just run once.
Just to add on that, as it runs every day, any new path categories that it sees, it will extract them, pop them into the platform, and then give you a heads up to say, hey, I found 5 or 10 or 15 new path categories. Please activate me. So as James said, it's constantly running, but not just filing the ones that you've given it, rules to file. It's also anything new. So within a few weeks or a month or so, it would have seen the full spectrum of your path categories stored within the platform. And then you're able to simply just enable them very quickly based on the rules, as James has mentioned, range, keywords, previous test result checks, etc., etc.
Thanks, Sanj. And just linking back to the other question before as well around the onboarding. What we've got now with this tool, because obviously we've been around for a while now, is when we do the configuration with you, which is a couple of calls, 45 minutes each call, we can Sanj and the team will pull up examples, or all around from all around the country of what other practices do. So obviously there's a whole tranche of path tests you'll know straight off the back of your head. You'll just say file normal, no problem. That one I want to check in the patient record. And then when you get to a cluster of pathology tests, we can show examples and say, well, this seems to be the average. These clients tend to supersede the lab, and then they check this. These ones don't. So we got it really quick. And Sanj actually runs all of those calls. He onboards all new clients. Sorry.
Shall I give a little insight as those onboarding calls?
I'll give it 2 minutes, and then Sanj, please. And then we'll jump into the next one. Yeah.
Just really quickly, as I say, the software is running. It extracts every path category it sees within your clinical system. We have a call. We review all of those path categories. There's 2 types of path categories. One where a range is present, i.e. MyBotGP has extracted the reference range from your lab, your local lab, and the other is a textual-based test, for example, hepatitis, HIV, etc. So with the numerical ranges, you then agree if you want to agree with the lab, or you want to supersede the lab, making it wider or tighter. And then, as James has mentioned, putting any contextual checks, i.e. the previous test results did not drop greater than 10% above or below. Checking the problem page for specific conditions, i.e. an absence of diabetes or hyperglycemia, things like that. So you can add further, rules associated with, is this patient in range? But also I want you to then check around the problem page and/or within the path report, because we actually extract the path report, and then you can do searches in that path report for respective keywords. So that's your numerical-based path categories. Now the textual ones, again, you can then search for specific words like no significant growth, no pathogens, not seen, not detected, negative, and file based on MyBotGP identifying that phrase or a collection of keywords. You simply just pop the words in. And just lastly, we can give you insights as to the commonly occurring keywords that are used across all of the labs. We've got hundreds and hundreds of clients now. So we pretty much know the kind of common words that are used for, to file these textual-based tests, so we can provide that information. As I say, we go live within 45 minutes.
Brilliant. Thank you, Sanj. A couple more here, and then we'll move on to Docman. Yes, we'll share all the slides. We'll share the webinar as well. Minimum period is 12 months, and there are no additional costs. This is an all-inclusive subscription. All of our products are sold in that way. No extra charges, unlimited volumes, unlimited test types. Same principle with Docman, unlimited letters, unlimited volumes. Thank you. Good. Some good questions there. Thank you very much. Docman platform now. Just before we finish this off, the principle behind this tool, as I think has been made clear, essentially is you're getting thousands and thousands of path tests a year that are coming through as normal. Complete waste of time. Yeah. in validating whether they're normal. We can have a tool do that for you in the background and ensure that you're only looking at pathology tests that you want to, not pathology tests that you have to. Okay, so I'm going to move to the next platform now, and then obviously there's safety and time savings as well. Right, so Sanj, is this share? Is the document sharing? Okay, thanks. Right, let me just put this to full screen. So firstly, you must be using Docman for this tool to work. So if we have anyone using EMIS here without Docman, unfortunately you must be using Docman. If there's anyone still on here from System 1, we will be releasing an equivalent for System 1 at some point, so just bear with us. That's coming soon. So the principle behind this tooling is to help. Now I think some of the questions here on the previous tool have been around AI and around certifications and stuff like that, and I think it's quite important to start this this presentation in the same way, and we'll stop for questions in a minute. There is nothing available in the market just today that is able to pick up a letter, read it, make medical decisions on that letter, and action them completely by itself. So unfortunately, there isn't tech there yet, and we don't believe there will be for another 4 or 5 years. There is tech available that will hazard a guess. It's quite expensive, but it hazards a guess, but they still give it to a human being to make a decision as to whether that guess is correct, because whoever actions that letter obviously takes responsibility for that patient. So it's really important to be mindful around where tooling starts and where it stops. Our tool doesn't hazard a guess. It also doesn't clinically code. That's not the piece that we're looking for. We do not see value in charging 4 to 5 times what we charge today to hazard a guess and still give it to a person who has to make a final decision, because that person who's making a final decision is still going to read the whole letter. They're not just going to see a code and just press enter and not check the context of it. So our tool, think of our tool as a Docman super user. It's someone that wants to use Docman, loves using Docman, loves reading letters, getting them onto the system, filing them, and distributing them appropriately. So I'll go through the logic of how it works now, but I'd just like to frame things quite clearly at the beginning, because I think with letter management, which is a highly complex, time-consuming process, there's a lot of misconceptions around what things do and what things don't do. So for the coders out there who are making medical decisions on letters and adding codes, you will still be doing that. The principle is that you won't have to do anything else. Everything else will be done for you. So this 8,500 scenario list patient receives approximately 125 letters a day. That number's fairly accurate as well, as it is with Path. Fairly accurate. Obviously, slightly different patient demographics. You might have slightly more, slightly less. There's a pretty accurate. 125 letters a day, 39,000 letters a year, coming in 7 days a week. So, and that's on an 8,500 list. So what that means is that team has to read 39,000 letters a year. Firstly, they need to validate all of the patients exist, because a large percentage of them won't, or there might be incorrect errors, and they're doing that manually. Then they have to transcribe those letters into a Docman template, one by one. IntelliSense will hazard a guess again, but it doesn't commit. So they have to do that. Then they have to file. So they've got to transcribe it 39,000 times into a Docman template. Then they've got to file 39,000 of them. That's before or during the process of actually working out which ones you need to see, which ones need to see someone who has the capability and accountability to make a decision based on that letter. No respite, 7 days a week letters are coming in. In addition to that, thousands of letters, you just don't need to see them. But for some reason, they're still being pushed past the team. So you have letters coming in that a highly skilled, overworked team has to read just to see that they don't have to read it. It's a very challenging process. So thousands of letters are processed manually, arriving 7 days a week. No natural pauses. Complexity, some letters need urgent action, some need clinical review, others just need filing. Every letter requires judgment, and a fragile process, as you all know. Holidays, sickness, recruitment gaps create backlogs, and manual processing as well invites human error. especially when you're under pressure. So think of MyBotGP as something that's going to do that for you. So based on this 8,500 list, it works 7 days a week, works out roughly 203 days, unbelievably, of time capacity can be reclaimed. In addition to that, zero backlogs, standardized rules. So for example, safeguarding letters, if you say we want all the safeguarding letters hidden by default, MyBotGP is always going to hide them. So now, MyBotGP is a Docman super user, so any of the functionality that you're using in Docman can be replicated. That's important because every practice on this call, in this webinar, will have a different Docman flow. They'll have different protocols at their practice in how they want to, where they want to, and how they want to route and file letters. And that's all done by just, tasks, templates, folders, and so on and so forth. All of that will still be available. It's just something else will do it for you. So MyBotGP will ingest. It's going to collect every letter and email directly from Docman. It's going to recognize the letter, the type, the sender, the hospital, the date, the patient. It's going to know whether it needs to take a letter from the middle of the page, top of the page, hospital name at the bottom of the page, middle of the page, all of the stuff that you're doing manually. It's going to validate the patient. So you've got that 39,000 patients, the letters being validated. It's then going to complete the Docman template by itself, completely by itself, and it's going to file all 39,000 of those letters completely, fully automated in the background, and spit out any ones obviously that need to be seen, that have failed, patients don't exist, and so on and so forth. In addition to that, you will tell us where you want those letters to go, and then we will connect that up in Docman for you. So you could say, these letters we like to give to a clinician, these letters at this practice we give to a coding team, these letters we don't need to see, or these letters we like to put in a folder. All of where you want it sent will go, it will go to those places. So you've got this workhorse, this automated platform, grabbing all of the letters, validating the patients, completing the Docman template, filing them, getting rid of the ones you don't need to see, and then pushing the ones that you do want to see through the protocols you have at the practice, tasks, templates, people, coding teams, whatever. It's completely up to you. You tell us, we'll show you what all of your letters are, and you say where you want them sent to. So that means that stuff like 111s, DNAs, all that type of stuff you don't need to see. In advance you don't need to see it, so you can just say file all of those, don't need to see them. But obviously for added safety, some of those 111s you might want to see. So some of the logic is file all 111s and DNAs, don't need to see them unless you see safeguarding or attempted suicide or a particular keyword on that 111, and then what we want you to do is to route that over here, put it in that folder, or put it in a template, or do whatever you do at the practice for those letters. It uses all of the Docman functionality. We can triage, it can triage to usual GP. There's some new functionality coming out in Docman, fortunately, which can handle duplicates. There's a pop-up that will come up and say, would you like to file this duplicate or not? We can incorporate that now into MyBotGP as well, as long as that's available in Docman, because essentially it's a Docman super user. So it applies fixed safeguarding rules. It goes without saying, with both products, the Path product and this product, there is a super comprehensive audit log. We will email you a spreadsheet with everything it's done that day, and there's obviously a really comprehensive audit log in the platform as well. We'll stop for questions in a moment, but same principle. This is the stuff around certification. This has a DCB 0129. Coming back to Ernest's question earlier on about Path, we have also drafted a template. Our clinical safety officer has also written a DCB 160 as well for this, a templated one, which we share with clients if they would like that. So we're closing the loop. It's also delivered from NHS Cloud in the same way. And these two, obviously, already. Here's just a little bit on the audit log, but essentially any letter that it's seen is that there's going to be a footprint of. The way that we charge for this letter is the same pricing mechanism as we do for the pathology platform, other than an additional £1,250 for configuration. So this 8,500 list comes in at 5,137 plus VAT, which essentially is 1,999, list times 30 pence, and then either 7 increments of 7, 6 or 5 pence for NHS Cloud. And that's unlimited letters and unlimited volumes. Okay, so what I'm going to do now is I'm going to put this over here, and then I'm going to stop sharing for a moment and let's see whether we have any questions come into the chat. So I can see a thing here. Will we share costs again? Yes, we will share costs again. Will you remain unlimited read throughput for path tests and letters indefinitely, or will there be a sliding scale in years to come? I don't. Yeah, I mean, I'm going to say yes. Yeah, we have no intention of changing our pricing mechanism in terms of unlimited. I don't see value in that. We're very proud of our kit. We think it's quite reasonably priced, and we want to be in thousands and thousands of GP practices, helping save time, and that's what we want to do. And it'll probably be more expensive for us to try and monitor volumes and keep sending out emails and different invoices and all of that type of stuff than it would. It's just a complete waste of time. So there's no plan on changing that. So any other questions? We have Sanj on the call, who is an expert read Docman as well. So please don't be shy. Pop them in the chat if you have questions, and we'll cover through them. Or even Path, if you've still got questions on Path, there's no issue. You can pop those in as well. I'll wait another minute or so. New to this, what is Docman? What does all surgeries have access? So Docman is a letter management platform. So essentially, hospitals will send, or various organisations will send letters to practices, and they are pushed through Docman as a way to pick them out, triage them, understand what they are, and then distribute them to the appropriate place. Some practices, not that many actually, the large proportion of EMIS practices will have Docman. Some don't use it. They have a workflow within EMIS. System one practices don't have Docman. They process the letters through internal functionality, but and again, we're building an automation for that as well. Any other questions? Oh, you're S1. That's why you don't know what Docman is. We're coming, so we'll keep your details. Path works. Our pathology management platform works with System 1, and then we will have an attaching docs equivalent to Docman at some point this year, I hope. Later on in the year for System 1. You have to ask Sanj that question. It's coming. It's coming. It's in testing at the moment. So the way that we build our products is obviously we build them with practices, and then they're run in test mode, and then as long as they pass all of the testing, then they move to sale. So it's in the final stages of testing, which basically means we've got to look at millions and millions of letters and see what happens. Okay, so what I'm going to do now is just give a quick summary of both the products. If anyone has any questions, please pop them in the chat. You can and we can stop and go back to those. So the principle behind our tooling for our pathology management platform is obviously enforce rules, make sure nothing slips through the net, and free clinical time, and enable clinicians to look at stuff that they need to look at. Our kit is the only kit that can read pathology test reports themselves. We can supersede lab ranges, do patient contextual checks, checking the patient record, work out percentage increases and decreases. We have 200 different pathology tests running through our platform now, which equates to pretty much 95% of your path tests. Some of our clients have got 2 labs, which actually means MyBotGP is processing and sifting through 400 different pathology tests for them. Annual subscription. 30 minutes a day for every clinician pretty much is allocated to this task when you take into consideration circling back, errors, missed stuff, double checking. We've got bundles of references. People are happy to not be doing path tests in the evening when they're at home. They can watch TV again. Other people saying it's freeing time at practice. Other people see more patients. Docman automation, same principle. This is based on letter management. What it's going to do is going to pick up all of your letters. It's going to validate all of your letters. In the scenario that we gave, that's 39,000 a year for an 8,500 list. It's going to get them onto the system. It's going to complete the Docman template by itself. It's going to file them all by itself, and it's going to free that highly skilled team up to just look at the letters and just see the letters that they need to see, rather than having to sift through thousands and thousands of letters a year that they don't need to see. Yeah, so any more questions, or before we round up? Sanj, is there anything you want to add?
No, I don't think so.
Yeah, okay. So it looks like here we go. Read document processing setups where practices use a third parties like Nova to code. Interesting. We do have clients, we do have a couple of clients who use our tool to get rid of, to get everything onto the system and remove anything that they don't need to see, and then push the remaining letters to a folder where a third-party company that they're paying will do the clinical coding. So that's possible, and for them there was value in paying someone to do the clinical coding, and they didn't want that company to see thousands of letters a year that they didn't need to see as well, and there was value in us. We've got a couple of clients that do that. They're quite big sites actually that do that, 20,000-30,000 lists, I believe, from memory. Yeah, there you go, your 25,000 list. Yeah, so I've seen that. We have seen that. MyBotGP will pick up and triage everything that they want it to, and triage the remaining to a third-party company that has nothing to do with us. Overall cost if one buys both packages, 9,000 list. Faisal, Farrell, will you pick that up and ping an email afterwards, please? I think I'm on the call. You there, Farrell?
Yes, yes, I am.
Okay, cool.
100%.
Okay, Farrell, thank you. Farrell, ping that over to you afterwards. Ernest.
Just a heads up. It's good that you're working with other document management systems, including the EMIS and System 1. A heads up, because the whole of Northwest London are moving away from using document. We're using document 10 at the moment, but the direction of travel is to give up document. A lot of them are not happy with it.
Yeah, 100%. Many practices has been installed in both products. 200 practices, 250 practices, I think, offhand, something like that. Now we're growing quite quickly. And any other questions? Okay, good. Unless there's any other questions, that's been a really, yeah, some really good questions there. Thank you for the input, everyone.